Hello, this video is about catheter ablation of atrial flutter and atrial tachycardia. Here for the atrial flutter, this is what we know is CTI and tricuspid valve junction. We start usually radiofrequency on there, and that is a CTI and IVC junction, and we turn the radiofrequency off. This is a patient with atrial flutter. You can appreciate the ablation catheter starting from CTI and TV junction. We slowly pull back the catheter towards the IVC, and we can see that it's contacting very well the tissue, but sometimes it is not as easy. If you appreciate that, there is a pouch there, and sometimes when we see that pouch, and you can see here that the patient is in clockwise atrial flutter, and when we bring the ablation catheter towards that very pouch, the atrial flutter was terminated. This is another case. If we are going to pull back this ablation catheter towards the IVC, here is going to be usually the trajectory, and you can appreciate that we are going to have a defect, and the catheter may not be able to touch the floor of that pouch if we don't recognize it on ice, and that is the area that we may not be able to ablate. Here you can appreciate, we can see that. And if I'm pulling the ablation catheter back, that is going to be the distance between the ablation catheter and the floor of the pouch. And that would be the area that we may have leak. So here, when we see that that pouch exists, we would be able to perform a U-curve like a candy cane and place the tip of the ablation catheter inside the pouch and finish the ablation and performing bidirectional block. Sometimes there is a eustachian valve which can make flutter ablation challenging. Here is an example of a eustachian valve. So that area is going to be easy to access with the ablation catheter, but that area very close to the eustachian valve is going to be very hard to access with the ablation catheter. So here is another example. You can appreciate that's a eustachian valve, and that is going to be the area which is going to be very hard to access with ablation catheter. But if we would be able to see it on the ice, we would be able to ablate it without any problem. Here it is a very large eustachian valve, and that area perhaps would be very difficult to perform catheter ablation if we don't see it on ice. Here, as you notice, we are performing catheter ablation and we are pulling back the ablation catheter, but since we know that that area would go under the pouch, we start performing right there a U-curve, and then slowly making the U-curve more and pulling the catheter back to be able to perform the entire CTI, which includes the eustachian valve as well. Sometimes you have to perform the entire eustachian valve, and even sometimes posterior part of that eustachian valve would have some muscles that needs to be ablated. Here, this is another patient with a eustachian valve, and if you notice, that area is going to be very hard to ablate if we don't have eyes to recognize it. So what we can do again, usually we go ahead and perform U-curve and bring the ablation catheter tip right under that eustachian valve to be able to have a successful ablation of the cavotricuspid isthmus as such. So we see that we have a very good contact to that part of the eustachian valve. Here, this is another example that ICE helped us to ablate. This is a patient who has undergone tricuspid valve annuloplasty, and you can see that that is the annuloplasty ring, and actually we had to go under that annuloplasty ring to be able to finish the CTI. Here we are ablating just on top of that annuloplasty ring, but we were not able to perform bidirectional block. And now we had to actually see that area and advance the ablation underneath. And you can see that because of that very narrow spot, we just did have a stem pop right there. But this lesion was the one that caused bidirectional block across the isthmus. Here, this is another case. This patient also had prior tricuspid valve annuloplasty, but had a very unusual shaped CTI. It is like a semi-square, and that was the area that we were supposed to ablate. But when we saw it on the ice, we were able to perform ablation without any difficulty. Here, as you notice, we are ablating right now at the junction of that very structure and the tricuspid valve. And then we just go and perform a U-curve and go inside that semi-square to finish the catheter ablation. Here, this is an example of a large pouch. Here you can see that pouch. So if we are going to pull back the ablation catheter, if we compare it to the patient A, which has a very smooth CTI, but patient B has that pouch, and that area that I'm going to show right now is going to be the area that we may have really some leakage, because the ablation catheter may not touch that area and may go over that area. So if we be able to see that area exist on the ice, we would be able to steer our ablation catheter right there and ablate it. And sometimes you can also perform a little bit counterclock of both ice and ablation catheter, and we can do a little bit lateral part of that pouch, which become more shallow and smoother to ablate. How about some atypical flutter and atrial tachycardia? This is a case of a atypical atrial flutter. Interestingly, it is a concentric activation, but the P wave are both positive on V1 and V6, and this was after a persistent atrial fibrillation ablation. So here we go and advance our HD grid inside the left atrium to be able to map the atrial tachycardia. Here you can appreciate the grid is inside the left atrial appendage. We are doing the voltage as well as activation map and creating the geometry. Here again, you can see that grid is inside the left atrial appendage. Here I want to show you another example of a left atrial appendage, which was a very large one. This is the one. And you can appreciate that actually the grid is floating inside that left atrial appendage, which is a very large appendage. You can also appreciate the ridge and left superior pulmonary vein. Remember, we move the HD grid slowly because we want to make sure that we get the entire activation of that very region. Here, we are advancing it towards the left superior pulmonary vein. That is a view that we could see both left atrial appendage, the ridge, as well as the left superior pulmonary vein. This is another view of that left superior pulmonary vein. Here that is. And that is our HD grid that we advance it in the left superior pulmonary vein. And of course, we do check the activation of the posterior, anterior, superior, and inferior part of that very vein that we are currently mapping. Now we find the left inferior pulmonary vein. We advance it inside the left pulmonary vein. And again, remember, we do movement a little bit slowly just to be able to get the entire activation. Here we go and clock our ICE catheter. We see the right inferior pulmonary vein, and we're going to advance our HD grid inside the right inferior pulmonary vein. After we get the geometry and activation of the right inferior pulmonary vein. If we go ahead and perform a little bit clockwise rotation of the ice, we would be able to see the right superior pulmonary vein, and that is a pulmonary artery. So we do the same maneuver with the grid, and we go ahead and advance the grid inside the right superior pulmonary vein. And here we are mapping the posterior part of the left atrium, and we know this is posterior because we can see the esophagus. And again, you can see the temperature probe inside the esophagus right there. Now we are mapping against the descending aorta. We are still in the posterior wall, but you can see the left pulmonary veins to the right. And here we can see that we are performing a U-curve and pulling the grid back. And now we are mapping the septum, and with like a paintbrush, we are releasing the curve and pulling back the grid to be able to do the entire area of the septum as posterior wall. Here now we are performing the mapping of the anterior part of the left atrium, because you can see the non-coronary cusp right there. This is another view. This is the left atrium, that is the left coronary cusp, that is the non-coronary cusp, and the right coronary cusp, RVOT and pulmonary artery. Here the ice is inside the left atrium. So this is one of the very interesting area to map, and this is against the left and non-coronary cusp, and you can see it on the mapping. So when you see on the mapping your HT grid here, you know that you are against those two coronary cusp, and mapping showed that the area of the slow conduction right there, this is the zone that we were going to go ablate, and by performing catheter ablation right there, we were able to terminate the atrial tachycardia. Here you can appreciate we are right there. This is the grid. So we are going to go ahead and pull back the grid, and we are going to advance our ablation catheter right there and perform catheter ablation. And now you can both look at the ice as well as the mapping system, and you want to make sure that you are performing over that line to be able to terminate this atrial tachycardia. So we are releasing the curve and going towards the right superior pulmonary vein. Remember, you have both the ice as well as the mapping system to be able to perform. And now you know that this is how we perform the lesions from that area of the coronary cusp towards the right superior pulmonary vein, which resulted in termination of atrial tachycardia into sinus rhythm. Here, this was a case interesting that we had a pouch in the mitral isthmus. You can appreciate that is the pouch right there that we were able to see it. Then when we were trying to map that mitral isthmus flutter, we found out about it. We put the HT grid right there to make sure that we do a detailed map. So we want to make sure that you see it. It is like having a pouch in the CTI. This is a pouch in mitral isthmus. And we advanced our ablation catheter there. And that was the area that we were able to successfully terminate the atrial tachycardia mitral isthmus flutter and resulted in block across the mitral isthmus. Here you can appreciate that is the area of the pouch that we were seeing it on the ice. And this is the clockwise mitral isthmus flutter, and when we were applying radiofrequency energy, we were able to terminate the atrial tachycardia, and by pacing from the left atrial appendage, you can appreciate that we have a concentric activation on the CS, which means we have a clockwise block on the mitral isthmus. Now we are going to talk about atrial tachycardia from right atrial appendage. Here you can appreciate that is the roof and apex of the right atrial appendage. That's the apex. And when you look at it closely, you can see that is the ablation catheter. And there is a small ridge there, and that ridge was inside the apex. And actually, atrial tachycardia was coming on the other side of the ridge. So since we were able to see it on the ICE, the ablation catheter was moved towards the other side of the ridge, which resulted in successful radiofrequency ablation. This is an example of focal atrial tachycardia. This patient had an atriotomy, and you can here see the right atrium. This is the lateral wall of the right atrium. And here you can see that scar tissue right there, which was secondary to prior atriotomy. And actually, the atrial tachycardia was coming from there. When we saw that scar tissue, we advanced our grid towards that very area, and then we were able to find the earliest activation right there. And then we went ahead, we advanced our ablation catheter there, and we had a successful catheter ablation. This was an interesting finding. This patient had a polyp-shaped structure inside the right atrium. You can see that this is like a polyp. And actually, this patient had multiple PACs for over 60 years. So he was 65, and apparently he had it ever since he was 5 years old. And when we saw that, we were not worried about getting a biopsy because the patient had had it for about 60 years. And catheter ablation of that polyp-shaped structure resulted in successful termination of PACs. Here is an example of visualization of the right-sided phrenic nerve during catheter ablation inside the right atrium and SVC. Here in this view, you can appreciate the right atrium, SVC, as well as the right atrial appendage. At this time, we go ahead and perform counterclockwise rotation of the ICE. Sometimes the ablation catheter comes into view, but we are going to be concentrating on the superior vena cava as well as the phrenic nerve. And you can appreciate that the phrenic nerve has different distances to the endothelium of the superior vena cava. Here again, we can see the phrenic nerve as well as the SVC. We have now pulled back the ICE inside the right atrium, and you can appreciate the right atrium as well as the phrenic nerve. And you can see the different distances from that phrenic nerve to the endocardium. Here, as we were performing high output pacing during radiofrequency application, we were not able to capture the phrenic nerve due to the very same distance. But as we were pulling the ablation catheter down towards the IVC, we could see that ablation catheter was getting very closer to the phrenic nerve. That's why we had already stopped performing any radiofrequency application before starting to capture the diaphragm. One last case, this is a atrial tachycardia on a patient that we had already done AFib ablation the same day. You can appreciate we are advancing the ICE. We can see that the patient has a tricuspid annuloplasty as well as a pacemaker lead. As we go and advance the ICE catheter inside the right ventricle, we clock it, and you can see that the patient has a mechanical mitral valve. And here you can see that mechanical mitral valve, and you can appreciate we are doing a mitral isthmus line from the left inferior pulmonary vein towards the mitral valve. And if you pay attention to that mechanical mitral valve movement during the catheter ablation, you see that it slows down right there. And that is the time that we were able to terminate the atrial flutter. Here you can appreciate here, as we are ablating it, we were able to terminate the atrial flutter into sinus rhythm. And interestingly, this patient had a single chamber pacemaker, and after this procedure, we went ahead and we upgraded the patient's pacemaker to a dual chamber pacemaker.